Hello and welcome to the Clinical Care Options Podcast. I'm your host, Hilary Tungal. In the second of 3 podcasts, we explore how to assess pruritus in PBC in the clinic, as well as pharmacologic and non-pharmacologic agents that can be used to manage pruritus. Today's episode features Marlyn Mayo, MD, from UT Southwestern Medical Center, Stuart Gordon, MD, from Henry Ford Health, and Pam Rivard, RN, a patient. This episode is part of a larger educational program titled Itching for More, Improving Care of Pruritus in PBC. To follow along with the slides, along with a link to the larger educational program, please visit the show notes for this episode. Now, let's get started as Dr. Mayo talks about assessing pruritus.
All right, so what do our guidelines say about assessing pruritus? The AASLD says that pruritus and the disease warrant separate evaluation and treatment. And the EASL guidelines say that evaluation should be done for all patients for the presence of symptoms, including pruritus. So here's data that we don't do a good job at that. This is a survey from the UK showing that the number of patients who are actually assessed for pruritus, and this is not at a single visit, this is over a 2-year period, is kind of just over the median at about 60%, almost 40% are never asked about it. And then here's another study from the US with similar results. This is the Target PBC study where patients were asked to fill out questionnaires, both the 5D itch and the PBC-40, and this categorized their itch as severe, very severe, severe, moderate, mild, or not present at all. And then they also asked the healthcare providers what they thought the patient's itch was, and the correlation was terrible. If the itch was qualified as very severe, then the providers got it right 100% of the time. But as the itching got a little bit less severe, providers almost always underestimated the severity of the itch. There are official tools that you can use. There's several 0 to 10 scales. There's the visual analog scale where you make a hash mark on the line. There is the numerical rating scale. There's several of these that go from 0 to 10. Typically on a 0 to 10 scale, anything over 4 to 6 is considered moderate and 7 to 8 is considered severe. Some of the more detailed scales are the 5D itch and the PBC-40, which really delve into the impact on quality of life of the itching, not just the severity. And in general, a good strategy, as Stuart started us off by saying, is the important part is just to ask, and ask at every visit, are you itching? And if the answer is yes, then following up with a question, how's it affecting your day-to-day life? And importantly, is it something you want to take medication for? Because that determines what your therapeutic discussion is going to be. Some patients will itch very severely but not want to take anything. Other patients have a mild itch and are miserable and would very much like to take something. And then in terms of some of these more elaborate scales like the PBC-40 and the 5D itch, those are difficult to administer during clinic under a time restraint, but they can be administered, like for example, in the waiting room while they're waiting for the visit to start. But just keep in mind if you do these that how a patient reports their itch verbally might be different than what they record on a form. So take-home points for this section are that all patients with PBC should be evaluated for pruritus. It should be evaluated separately than the underlying disease. It should be evaluated each visit because as we heard from Pam, it fluctuates from time to time. And that's key to understanding how severe it is and whether the treatments are working. And there are more extensive tools available if you want to use them. So now I'm going to turn over for the second part of our program to my colleague, Stuart Gordon.
Thanks very much, Marlyn. That was sort of a nice overview. You know, you sort of bring back all these memories of patients and their stories. And another was a patient who couldn't wear short sleeves in the summertime because she didn't want to show her arms, and little things like that about how the itch then translates into quality of life issues. So the next section is sort of moving on to beyond the biochemical response, managing pruritus in clinical practice. And what do we do in the real world setting? We're committed to finding a pruritus treatment that can provide relief and to set appropriate patient expectations, create an individual treatment plan that incorporates patient preferences, modify therapy based on patient responses and tolerability, and obviously considering clinical trials. So this is sort of a nice feel-good type of approach. Unfortunately, in the real world, we don't have a lot of options that are available to us. as far as non-pharmacologic treatments. And I think this is what a lot of us are left with in the clinic is topical moisturizers, which is what a lot of the dermatologists provide, cool showers, fragrance-free soaps and laundry detergents, avoidance of irritating fabrics, sticking with cottons and some of the non-irritating fabrics. But I think this is, again, something where we would really want to hear from the patient what helps you the most, non-pharmacologic.
Just like any other PBCer in the room or in your practice, it's been decades of trying to figure what works for me and what doesn't. Many of these things would come right out of an allergy or a dermatology flyer as well. Skin is skin. Topical moisturizers, I have found something that's even better for me when this insane itching starts. I keep my nails short. People do tear and wound themselves terribly. And sometimes they can scratch all day and not do it, and then all of a sudden there's a wound. I have found that when I am itching terribly, an actual lubricant, not just a moisturizer. I don't care if it's Vaseline. Some thick, oily something or other. Most of us have some oils at home, I don't care if it's olive oil out of the kitchen or coconut oil. The slicker it is, if I'm doing this, I'm not creating a friction burn. That helps me immensely with a really serious itch. I know I'm going to scratch. I know this is going to be ugly, and I know it's going to endure. It's a bad spell. So beyond moisturizers, a very thick lubricant. Cool showers, I've done both. I like to experiment on myself. What happens if I take a hot scalding bath and Epsom salts, let alone a cool shower? To each their own. I've heard people tell me that one or the other helps. Obviously, we all know with skin, heat does intensify a lot of feelings, sensitivities. So I tend to go with the cool shower. The fragrance-free soaps and laundry detergents has been my lifetime experience, as I said, through allergy and dermatology. None of that worked for me. I never found that it was a sensitivity to any of those things, although I was very methodical and followed directions as a good patient and eliminated those things. It didn't change anything. So I can't really zero in on that other than that wasn't effective for me to avoid those things. Irritating fabrics, I think that could have a subcategory, again, with skin. Anything that has elastic in it, anything that binds the skin, underwear, socks. If your feet tend to swell and your straps on your shoes or sandals are tight, that's going to be an area where you start itching first. That's why I don't wear a watch anymore. Many times if my hands, top and palms are itching, I don't wear rings because that just seems to be a spot where it'll start. Before I know it, I'm itching all over. So myself, I have not noticed a difference between synthetics and cottons. I'll leave it at that.
Oh, very helpful. Yeah.
It has really been just a lifetime of trying to solve it on my own because really great doctors who I trust my life with haven't been able to offer solutions. And they've been very honest that the industry hasn't caught up with products or medicines for us. And that's the best I think you can do as a practitioner. If you are not aware of or do not know, it's not out there, and you tell me that, kind of leaves me up to my own devices, and I've been very creative. So I'll leave it at that.
Very nice, Pam. It's really more than you know. It's very helpful, and it's a nice lead in to the next section, which is that hopefully there is some hope along the way. So what are the current recommendations, both drug and non-drug, for the management of pruritus? Well, we turn to our guidelines, and here we are at the AASLD, and what better place than to discuss the AASLD guidelines? And they have recommended that the first line of treatment should be to increase pruritogen excretion, which is in the form of bile acid resins. And it was interesting, reading up on this, I saw papers from the 1960s from Sheila Sherlock, and really things haven't changed in half a century, where we're still recommending bile acid resins. And we'll talk about some of the concerns about cholestyramine. Second line treatment includes reduction of pruritogen production, so to speak, which would include rifampin. Rifampin has also been around for a long time, and we'll talk a little bit about the pros and cons of using it. I've used it. It's been helpful when I do use it, but we always do it with a little bit of trepidation. and then modulation of the central itch pathway. And as we're hearing, it's not a typical itch. It may be mediated by other inflammatory cytokines. And so naltrexone, the opioid antagonist, has been advocated in certain cases, and we'll talk about that a little bit more, as well as sertraline, the SSRI, and was first described here by Dr. Mayo. And we'll talk a little bit about whether sertraline might be helpful in this particular setting. And then we get into the third line, which is a whole list of different options that have been tried over the years, and this is by no means a complete list. The gabapentin and the phenobarbital are probably getting at some of the central mechanisms involved. Plasma exchange, plasmapheresis have been used in some of the more severe categories. The MARS device, the nasal biliary drainage, UV light, and as we mentioned, topical therapy. And there's a whole list of others. At one time, there was actually potentially a role for transplant. That's become much more difficult in recent times. But it's important to mention here that UDCA is the first-line treatment for PBC, but it really has no role in the reduction of pruritus in patients with PBC. There are actually some early papers early on suggesting that some people actually get worse with their pruritus with UDCA. So it's not a treatment for the pruritus itself. Pruritus must be treated independently of the PBC. So the first-line treatment of bile acid resins ideally would be cholestyramine. It could be given up to 4 times a day. It's a packet of 4 grams each. It's generally started off with 2 times a day, but you can go up to, 6. I've never gone more than 4 times a day. And ideally, when the gallbladder is in, to give it 30 minutes before breakfast, 30 minutes after breakfast, 30 minutes before dinner, at bedtime, to sort of work more effectively on the putative bile mechanism for the cause of the pruritus. But all of the considerations and challenges in using cholestyramine include that it can interfere with the absorption of other drugs. So it must be given 1 hour prior or 4 hours after other medications to avoid interference with these other meds. It's a gritty, foul-tasting powder that's mixed up with water. It's very poorly tolerated, as you all know, nausea, bloating, constipation, and diarrhea. There are also oral forms of the bile acid resins, including cholecyverim and cholestyramine, both of which are in tablet forms and can be given during the course of the day, BID or over the course of the day, but likewise associated with GI toxicity, including constipation and others. So the second-line type therapies include rifampicin. It says 150 to 600. I personally have not gone beyond 150 a day, and we do it with a little bit of concern. So there is well-recognized hepatotoxicity in 10 to 15% with patients taking rifampicin. And that risk, and it's a cholestatic type of injury as well, and that risk is thought to increase with the severity of the underlying liver disease itself. And often these are the people who itch the most, and it is to be avoided once the bilirubin starts rising above 2, 2.5. There are a number of drug-drug interactions, including some of the PPARs that we'll be discussing later, and we really don't want to be using it with other medications that it can be interfering with the absorption. You'll frequently get a flag from the Epic people or whatever your EMR. Are you sure you want to write for rifampin? It's interacting with this or with that. Naltrexone is an opioid antagonist, and I personally don't have a lot of experience with it. Rifampin, when it works, really works beautifully, and the patients like it and really don't want to go off of it. And the same I'm hearing with naltrexone, but there's the concern here about withdrawal symptoms, and we don't like to use this type of medication for a prolonged period of time. The SSRI sertraline has been reported, at least in 1 or 2 reports, to improve the pruritus of PBC, and this benefit is felt to be independent of its improvement in depression, and fortunately is free of significant toxicity. There are patient resources, and no program like this should go without discussing some of these resources. I'll frequently place my patients in touch with the PBCers, pbcers.org, and then the largest probably in the world is out of the UK, the PBC Foundation.org. There's PBC Society in Canada and others mentioned here, including the Liver Foundation. And then, of course, clinicaltrials.gov. There are ongoing clinical trials, and we'll be talking about those coming up shortly. And so I guess the questions that I would pose to you, Marlyn, in no particular order, is one, why might there be a discrepancy between the healthcare provider assessment of itch and the patient-reported severity? We'll start off with that one.
So I think it's important to recognize that there is a difference, and I think there's probably a couple of reasons. First, what we write down is not necessarily what we say, and I think that's true for patients. We already heard that even the patient is cognizant of the limited time they have with the provider, and maybe they want to spend that time focusing on something else that's bothering them. Whereas if they're filling out a questionnaire, then they're sitting down and exclusively focused on the pruritus. But the same is true for the healthcare provider. So they might discuss something, but not necessarily write it in the note because of, again, time constraints. Or I know a lot of people have like note templates, and so every note looks very much like the other note. And that might be part of it. So I think both parties, what is written is not always necessarily reflective of what is said. As a side note, I think it would be a really interesting study in the future to see if that changes with AI-generated notes. And that is, kind of the future, right? Where you have your cell phone and you turn it on and it listens to the conversation and then translates it into a note. And maybe that would be more accurate. I don't know. I think the studies that show the difference between patient healthcare providers and patients are not always, perspective. I think they can also be subject to recall bias. Like you may think you talked about it, but you didn't. So I think those are two of the big reasons. And then sometimes people are talking and other people are not listening. That happens too.
Which of these scores do you use? A lot of these are used in clinical trials, and you sort of nicely outlined the various different parameters that are used to assess severity, but what do you use, if any, in your clinical practice to assess pruritus?
Full disclosure is that I wrote the 5D, so I'm highly biased towards it. And I'm very well of all the work that went in to make sure that it captures the totality of the itch experience for the patient. But even for me, that's too long of a scale to do in the clinic. The first time somebody does it, it takes them about 5 minutes. As they get used to the scale, it gets down to about 30 seconds, which is fine for a clinical trial. But, my established slots are, 15 to 20 minutes. And most of that is taken up by the MA, getting the patient vitalized and put in the room. And another 5 minutes for parking. And I have precious amount of time left with the patient, and I don't want to spend it sitting there watching them trying to interpret a question on a form. So I also tend to just kind of do an open-ended, mild, moderate, severe. I have focused more on what is the impact on your life than I do on the number.
No, and that's where we get some of these issues that you hadn't even thought about before of how the itch is actually affecting their life. And I think most of us are doing this mild, moderate to severe, 1 to 10. And I would agree with you. Well, we talked about different treatments that are out there, none of them FDA-approved for the management of pruritus. How do you discuss pharmacologic treatments, non-pharmacologic management of those that we've talked about so far? Which have you used? Not just first line, but also for the more severe.
Right. So you very nicely went over the ASLD guidelines and what we have as first line, second line, third line. And to be honest, I don't do it that way. I don't consider one first line, one second line, and one third line. For me personally, it's more like playing a game of cards. And I have a deck of cards, or, a hand. And it's a very shared decision-making with the patient. And I lay all the cards down and I say, these are the ones that we have. None of them are usually going to completely obliterate the itch, but all of them have been shown to be helpful in one study or another, and then go through a detailed discussion about what it is that they're willing to accept and what their priorities are in a treatment. So The side effects are different as you reviewed for each one. So one might have a risk of hepatitis. Another one might have a risk of interacting with medications. Another one might cause diarrhea. Another one might cause constipation. And patients will have very distinct opinions about what they're willing to tolerate for their itch. And so we kind of go through that and come to a decision. And so all of those therapies, I'd be willing to use any of them first line if I think that's the best fit for that patient. And it does take time to do that, but I would rather spend the time discussing that than having them fill out a questionnaire.
There's so much to discuss at each visit. We're just sort of touching on one of the manifestations of PBC. So I think that the take-home points here then are non-pharmacologic options for mild pruritus include moisturizer use, and you sort of nicely discuss what type of moisturizers, cool showers, avoidance of irritating fabrics or soaps. Guideline-based pharmacologic options for the moderate to severe pruritus currently at this stage in 2024 include bile acid resins, rifampin, naltrexone, or sertraline.
Thank you, Doctors Mayo and Gordon and Pam, and many thanks to you, our listeners, for joining us. As a reminder, to view the full program, Itching for More, Improving Care of Pruritus in PBC, please click the link in the show notes. And be sure to check back regularly for more episodes on important topics.